Welcome back to another explainer. Today, we're putting on our detective hats to investigate one of the most complex, fascinating, and honestly most impactful conditions in neurology, multiple sclerosis. If you are a focused medical learner who already knows the basics and wants a high-yield, postgraduate level deep dive, well, you are in exactly the right place. We're going to break down the evidence, the core mechanisms, and the absolute latest diagnostic criteria so you can truly understand what's happening inside the central nervous system. Let's get right into it.
Here is our syllabus for today's analysis. We'll start with Part 1, the crime scene. Then Part 2, the suspects and victims. Part 3, the modus operandi. And finally, Part 4, the forensic tools.
Starting off with Part 1, the crime scene. Let's look at the definition and pathophysiology. To lay our groundwork, let's formally define what we're dealing with. Multiple sclerosis is a chronic, immune-mediated, inflammatory, demyelinating disease. Crucially, it is localized exclusively to the central nervous system, meaning the brain, the spinal cord, and the optic nerves. And why does this matter so much? Because MS is actually the leading cause of permanent, non-traumatic neurologic disability in young adults. This isn't just an abstract disease process, it's something that drastically alters the life trajectory of patients right in the prime of their lives.
So how exactly does this biological crime unfold? It generally operates in two distinct, though sometimes overlapping phases. Step 1 is the inflammatory phase. This is where activated peripheral lymphocytes, specifically your T and B cells, basically go rogue. They breach the blood-brain barrier, release a storm of cytokines, activate macrophages, and actively strip away the protective myelin sheath. Then we hit Step 2, the degenerative phase. This is driven by microglial activation and toxic astrocytes. The absolutely crucial takeaway here is that while those initial attacks cause acute demyelination, it's the subsequent axonal loss in the degenerative phase that ultimately locks in that permanent disability.
Moving right along to Part 2, the suspects and victims. Let's talk epidemiology and risk factors.
So who exactly gets this disease? 3 to 1. That is the approximate female-to-male ratio for typical MS diagnoses. And what's really interesting is that this disparity actually appears to be increasing over time. The peak onset usually hits between 20 and 40 years of age. Geography also plays a really fascinating role here, with the prevalence going up at higher latitudes, closer to the poles. But overall, the demographic profile is undeniably skewed toward young adult females.
Now, the underlying triggers behind MS are where the plot really thickens. The strongest environmental link is the Epstein-Barr virus, or EBV. Get this, seroconversion to EBV doesn't just slightly bump up your chances, it increases MS risk by over 30-fold. It's a massive suspect. We also see an inverse relationship with vitamin D, meaning less sunlight equals a higher risk. Tobacco smoking is another culprit that actively accelerates the transition to secondary progression. And childhood obesity is a major factor, particularly for females. We also have to factor in genetics. The HLA-DRB1/15 allele plays a role, but it only explains about 10% of the genetic risk. So MS is really this complex, perfect storm of environment, viral exposure, and host genetics.
Part 3. The modus operandi. Recognizing the clinical signs of the disease.
Because MS can hit any part of the central nervous system, the symptoms are incredibly diverse. It's like a clinical puzzle. Visual and sensory disturbances are huge, affecting roughly 80 to 85% of patients. Visual issues very often present as optic neuritis, which is a painful, unilateral vision loss, frequently accompanied by red color desaturation or sometimes diplopia. Sensory issues typically show up as severe numbness or pins and needles. Motor symptoms present as asymmetric weakness, deep fatigue, and spasticity that's usually worse in the legs. And we can't forget autonomic dysfunction. Up to 90% of patients will experience severe bladder urgency.
Okay, here is some high-yield medical trivia that you definitely want to keep in your back pocket. These are two classic paroxysmal signs that are unique to demyelinating diseases. First, Uthoff phenomenon. This is a temporary worsening of neurological symptoms when a patient's core body temperature rises, like when they take a hot shower or have a fever. Second is Lemritz sign. This is literally an electric shock-like sensation that shoots down the spine and into the limbs when the patient flexes their neck forward. If your patient tells you they feel a zap down their back every time they look down at their phone, your MS radar should instantly go off.
When we get to the physical exam, we're hunting for objective evidence. In the eyes, we might find a relative afferent pupillary defect, you might know it as a Marcus gun pupil, or internuclear ophthalmoplegia, which is impaired adduction with abducting nystagmus. Motor exams will often reveal classic upper motor neuron signs, so expect to see hyperreflexia, sustained clonus, and a positive Babinski sign. And I want to pause here to highlight a very specific clinical pearl, McDonald sign. This is a highly specific MS sign characterized by rapidly increasing weakness and gait impairment that is explicitly triggered by physical exertion.
Finally, Part 4, the forensic tools, investigations, and the diagnostic criteria.
So we know what the clinical signs look like, but how do we definitively prove it's MS and not a mimic? That brings us to our gold standard neuroimaging. When you look at a classic MS brain MRI, you're searching for these white, hyperintense, ovoid lesions radiating outward perpendicular to the lateral ventricles. We call these Dawson fingers. They beautifully follow the path of deep medullary veins and are an absolute hallmark radiographic sign of inflammatory demyelination in MS. It is a classic medical school learning moment every time you spot them. Beyond those Dawson fingers, we are looking for a few very specific hallmarks on an MRI of at least 1.5 Tesla. We want to spot T2 or flare hyperintensities in key regions: periventricular, cortical, or juxtacortical, infratentorial, and the spinal cord. Now, contrast is absolutely key here. If a lesion enhances with gadolinium, that tells us there's a breakdown of the blood-brain barrier and active ongoing inflammation. On the flip side, T1 hypointensities, which we often refer to as black holes, represent areas of chronic, permanent axonal loss. And of course, we must check the spinal cord for discrete white matter plaques, which is incredibly important for progressive forms of the disease.
All of this imaging data feeds directly into our diagnostic framework known as the McDonald criteria, which relies heavily on proving two absolute requirements. First up is dissemination in space, or DIS. We simply have to prove that the disease has struck in multiple, distinct anatomical locations within the CNS. Second is dissemination in time, or DIT. We have to prove these attacks are happening over a period of time, rather than just one isolated event. A fantastic way to instantly prove dissemination in time is by finding simultaneous gadolinium-enhancing and non-enhancing lesions on a single MRI, because it proves you're looking at both new active inflammation and older established damage at the exact same time.
Now, if the clinical or imaging evidence is a bit ambiguous, a lumbar puncture becomes an essential ancillary tool. When analyzing the cerebral fluid, we traditionally look for oligoclonal bands. Finding two or more bands that are unique to the CSF indicates intrathecal antibody production. But I really want you to pay attention to this newer development: kappa-free light chains, or KFLC. This is a biomarker with extremely high diagnostic accuracy, and it has actually been formally accepted in the newly updated 2024 revisions of the McDonald criteria to help satisfy those strict diagnostic requirements. It's a real game changer for diagnosis.
Once we've nailed down the diagnosis, we have to assign a phenotype, because the specific disease course dictates exactly how we manage the patient. Clinically isolated syndrome, or CIS, is simply that first initial attack. If they meet full criteria, they're generally diagnosed with relapsing remitting MS, which is characterized by sharp attacks followed by periods of recovery. Then there's primary progressive MS, or PPMS, making up about 10 to 15% of cases. This phenotype shows a progressive accumulation of disability right from day one, without any distinct relapses. Finally, secondary progressive MS is a retrospective diagnosis where an initial relapsing remitting course eventually shifts into a steady, gradual worsening of function.
To wrap up our investigation today, I want to leave you with a provocative thought. We've just seen how diagnostic criteria are actively evolving, especially with the 2024 inclusion of kappa-free light chains. As our forensic tools become sharper and more sophisticated, how will these emerging biomarkers continue to reshape our ability to detect silent, subclinical MS even earlier? If we catch the inflammation at its absolute inception, could we eventually intervene before that very first permanent black hole even has a chance to form? It's a really exciting frontier in neurology. Keep exploring, keep asking those big questions, and I will see you in the next explainer.